Hello, friends. I'm Kush Khandelwal, and this is Ageless Athlete. A few years ago, I started asking questions that would not leave me alone. Why do some people keep pushing mentally, physically, spiritually long after others burn out or break down? What does it really mean to age well when you still crave movement, meaning, and mastery? This show is my search for answers. Each week, I talk to elite athletes, everyday adventurers, and pioneering researchers who are stretching the limits of what's possible across age, injury, illness, and self doubt. You will hear hard won lessons, untold stories, and science backed strategies for building a body and mindset that lasts. For those of us joining for the first time, welcome to the show. For the rest, thank you for joining us again. Time is our most valuable asset, and I deeply appreciate you giving me your time today.
People over the age of 50 who were told to have either a total knee or partial knee replacement, artificial replacement for their arthritis. We went ahead and put back in a new meniscus and grafted their damaged articular cartilage to regrow it. And when we looked at and tracked 85 of these patients over the course of 25 years, about 42% of them got about 8.5 years of relief from the biologic replacement before they had to have partial or total knee replacement. And the other 48% of them never went on to having that partial or total knee. So many of the patients referred for a total knee replacement actually don't need a total knee replacement. Because of the precision of robotics, we can now get rid of the bone cement that we used to use that limited people's return to impact sports. So we now can permit people to go back to running and playing tennis on their total knee replacement, which in the past we weren't really able to do. So there have been these amazing improvements that we've been part of as both inventors and participants in this wonderful era of having new tools to get people back to sport.
Today's episode is a little different. Most conversations on Ageless Athlete live inside lived experience. Stories earned through years of training, injury, adaptation, and return. Today's conversation looks forward instead of back. My guest today is Dr. Kevin Stone of the Stone Clinic. And this is not an episode about quick fixes or miracle cures. It's about what has changed underneath the surface of sports medicine, the advancements over the last decade, particularly for aging athletes who want more than just symptom management. We talk about joints not as failing parts, but as systems that can sometimes be repaired, regenerated, or meaningfully extended. We talk about cartilage, the tissue most of us are told simply wears out, and what's now possible when you challenge that assumption. And we talk about why the future of orthopedic care may look less like replacement and more like restoration. If you are an athlete in your 40s, 50s, 60s, and beyond who's been told this is just how it goes, this conversation offers a different frame. Not false hope, but informed possibility. You will hear where the science is genuinely promising, where it is still uncertain, and how to think clearly about emerging options without chasing hype. This matters now because longevity isn't just about how long we live. It's about whether we can continue doing the things that give our lives shape and meaning. And regular listeners know this. We don't talk about how we can extend our years by just looking at science and looking at taking pills. We talk about how we can add more healthful years to our lives, how we can continue doing things that we love. This episode, well, it won't tell you what to do, but it will help you ask better questions at a moment when the answers are finally starting to change. Dr. Stone, I always like to start off with this question, which is, where are you right now and what did you have for breakfast this morning?
I am in my happy space. It's number one. And that's because I'm at the Stone Clinic in San Francisco. And on Mondays, I see patients and interact with our research team. in preparation for Tuesdays where we do surgical repair of injured athletes and people with arthritis. And I start out my day on Monday mornings out on the coast and usually ride my bike in towards Mill Valley and then come over to the city. So it's a good way to start off every Monday.
Oh, that's lovely. So do you ride your bike from your
Today
place all the way
over to Mill Valley and then come into the city.
Oh, that's excellent. What a beautiful, energetic way to set the tone for the day and the week.
Yep.
And as we were just discussing, it's a gorgeous day in San Francisco. I bet that made your ride in just that much more nourishing.
It makes it even better because I ride to Sausalito and then I take a small motorboat that I keep there over to the city. So I get the best of both worlds where we live here, riding in the hills and beautiful part of the Bay Area and using San Francisco Bay as much as possible.
Incredible. Yeah, this is just using one's environment to one's full advantage, even when one is commuting.
Of course.
Excellent. Dr. Stone, it is so refreshing to talk with someone who actually lives what they teach. You are moving, you are playing, you're staying active, and you're not just disseminating all of it in theory. So before we dive into the details, for listeners who might not know you yet, could you give us a quick snapshot of what you do at the Stone Clinic and the kinds of people you help?
Sure. So I'm fortunate to be an orthopedic surgeon, and I divide my life between clinical practice, where I'm treating primarily knee, shoulder, and ankle patients, usually injured athletes or people with arthritis. And I also run a public nonprofit research foundation called Stone Research, which you can find information about at stoneresearch.org. And then my third part of my life is that I invent products and devices and things that would help people and help the field of orthopedic surgery, help people stay active. So I get to divide my life three ways that way, and every day, every patient that I see, every surgical technique that we do, the focus is how do we make it a little bit better every single time. So there's no single standard procedure in a sense. I don't believe in that. I think there's almost everything we can do, we can make better. And that the science around making them better is a key part of how I practice. And that's why the Public Research Foundation is intimately connected to the Stone Clinic. So that almost every patient is entered into one research outcome study or another. And the reason for that is that I don't believe that a doctor should do something to or put something in a patient that they either don't know the outcome of or aren't trying to study or improve the outcome. And so all the things that we're doing in terms of new surgical techniques around treating, preventing, curing arthritis or accelerating healing, all of these are being entered into a research database. All of them are being exposed to different things that are happening in our field to see if we can make them better.
I love it, Dr. Stone. Yeah, your work sounds comprehensive. So I can see that you are continuously innovating. And the part about your work, which is particularly attractive to listeners of this podcast, lifelong athletes, people who want to keep moving till the day they cannot move anymore. So could you give us also a snapshot of the type of people who you are most likely to help?
Sure. So I see athletes of all ages. And so there's the high school and college athlete who tears their meniscus the way I did when I was in college and tears their ACL or dislocates their shoulder, the sort of the typical sports injuries that we see in young athletes. And then there's also all the middle-aged folks, the folks who had their meniscus taken out when they were in high school or college, or injured their knee then, and then are starting to develop arthritis. And then I have a wide range of patients who are referred from pickleball these days because our 50 to 80-year-olds are picking up pickleball at an enormously rapid rate, and they're unfortunately not prepared for how ballistic that sport is. And so I see lots of Achilles ruptures and shoulder tear, rotator cuff tears, and other injuries from pickleball. So we see a wide range of athletes. All of them have the goal of, hey, look, how do I stay playing my sport? Or I've been told I can't run, or I've been told I need a knee replacement, or I've been told things that are not as conducive to keeping playing the way they'd like to. And that's our job. We're very focused on how we keep people playing for a lifetime, how we keep them engaged in sport. which we think is just the key to a lifetime of happiness.
Friends, it means a lot that you're here. I pour a ton of heart into the show. The research, the interviews, the editing, it's all me, trying to share stories that matter. If Ageless Athlete has ever made you feel seen, inspired you, or just kept you company on a long drive, or better, over a run or a bike ride, I would be so grateful if you considered supporting it. Even a small amount helps keep it going, helps keep bringing the show to you for free. You can chip in at buymeacoffee.com/agelessathlete. Again, buymeacoffee.com/agelessathlete. You can find the link on the show notes as well. Thank you for listening and for being part of this.
Your mission resonates strongly because it's not just helping people regain day-to-day functions. It's about helping them regain the joy that they find when they're out there doing the activities they love. So it really is a quality of life change that you are enabling, or at least you are helping maintain. So people who are listening to this podcast, I think they will want to listen strongly because, yes, these people have had their share of injuries, the type of stuff you describe. Yeah, torn meniscuses, of course, but also worn out cartilages where the standard treatment might have been, hey, let's go and get that joint replaced. From your front row seat, Dr. Stone, so what is actually possible today for repairing or even regenerating joints? So what can orthopedics do today that wasn't realistic even 10 years ago?
So in a broad sense, in the past, when you saw a doctor with a torn tissue, whether it's torn meniscus or other tissues in the knee joint, shoulder, or ankle, they'd often take out the tissue and then inject cortisone or try to keep you going until you come back to me when you're ready for your knee replacement, or live with your pain until you're older, or the whole field was around removing damaged tissue. And that's changed dramatically now. We're in what I call the anabolic era of orthopedics, which means that instead of taking tissues out, we put tissues back in and we stimulate them to heal. So a great example is the meniscus cartilage. Injured about 1 million times per year in the United States alone. More than 90% of these things are taken out or the tissue is trimmed. The rest are repaired and very few are replaced. And we developed the technology and a lot of the techniques for replacing the meniscus cartilage using a donor allograft tissue. In the past, we also invented and developed a collagen scaffold for regrowing the tissue. That's not currently on the market, but it's about to come back. But the meniscus tissues are available to replace the meniscus. So all these people who've been playing and impacting on their knee without a meniscus and developing arthritis, we think the moment the tissue comes out, it should be replaced. And then we think for those who develop pain, we can put a meniscus back in and help them restore their sports and diminish their pain. So remember, I told you that we're in an academic environment here as well. So we published a paper on people over the age of 50 who were told to have either a total knee or partial knee replacement, artificial replacement for their arthritis. And as long as they still had some joint space remaining, we went ahead, if they wanted us to, and put back in a new meniscus and grafted their damaged articular cartilage to regrow it. And when we looked at and tracked 85 of these patients over the course of 25 years, about 42% of them got about 8.5 years of relief from the biologic replacement before they had to have partial or total knee replacement. And the other 48% of them never went on to having that partial or total knee in the 2 to 25 year outcome study that we did. So we know now that we can do a biologic joint replacement often when we thought we had to do an artificial joint replacement. Now, the other side to that is that because of robotics, we now can do partial knee replacements so much better than we could ever do them in the past. So many of the patients referred for a total knee replacement actually don't need a total knee replacement. They can have a partial or a biologic. And then those that do need a total knee replacement, because of the precision of robotics, we can now get rid of the bone cement that we used to use that limited people's return to impact sports. So we now can permit people to go back to running and playing tennis on their total knee replacement, which in the past we weren't really able to do. So there have been these amazing improvements that we've been part of as both inventors and participants in this wonderful era of having new tools to get people back to sport. And it's not just the knee joint. The ankle joint has come along in dramatic ways as well. The shoulder is not quite as advanced as the ankle and knee are in our options for biologic treatments, but still even there are some better tools than we ever had before.
Wow, Dr. Stone. Yeah, you threw out a few different things at us, and I'm going to try to see if I can go down further with some of the things you talked about. So going back to that illustration you provided, which is somebody who comes to you and they may have a combination of things happening with their knee. So let's stick with the knee illustration. So we talked about a meniscus that might be torn. We also talked about cartilage that had eroded. So the meniscus bit, I understand. But are you telling us that there is a possibility that people who have, let's say, lost all cartilage and they hear that their knee is bone on bone, so those people also have possibilities here that allow them to regain full function without the need for their knees being replaced?
Yes. So the guideline in the knee joint is bone on bone. If the X-ray shows bone on bone, then there's not enough space usually to replace it with biologic tissues. In that case, most of those people are only bone on bone in one compartment. And so they can have a partial knee replacement, which is a procedure done robotically, takes about 1 hour. It's an outpatient procedure. You come into the clinic the next day and start your exercises right away. 98% of those patients between 3 and 4 months will say it's a forgotten knee. And we've had patients go back to running across the United States on these things, so it can return them to having a normal feeling knee. Now, if they have cartilage damage, remember there's 2 types of cartilage in the knee. There's the articular cartilage, that white shiny surface when you crack open the chicken leg. That's what, when you get arthritis, it's wearing that down to the bone. And the second type of cartilage is meniscus cartilage, the shock absorber inside the knee. So when they wear down the articular cartilage, the bearing surface, that can now be regrown in many instances. And we do that all inside the knee. We take some of their own bone and cartilage, create a paste out of it, and then we're able to paste that material back onto their damaged area inside the knee. And we're just doing a number of studies right now in various animal models to see if we can improve that paste graft with various growth factors, cells, and Williams jelly, and a host of factors that augment healing. But right now, we can do a pretty good paste for many people who have worn part of their articular cartilage down. So the answer is yes. Don't live with the advice of wait until your knee replacement. There are a lot of things that can be done now to get you back in playing sports. Now, I will tell you that almost every one of these procedures these days, the results are improved by adding injections of lubrication and growth factors to them. So a dramatic change in our practice and many people's practices over the last decade has been when we do a surgical repair, how do we augment it to get it to heal faster? So let me explain. So if I ask any patient a year after their knee surgery, what was the worst thing about it? They never say it was the pain. They almost always say it took them a year to come back from the muscle injury or get their muscle atrophy back or their tissues strong enough. Why does it take collagen fibers a year to mature? Well, it turns out we can accelerate some of that healing doing a host of things. And we're driven on the research side to figure out how we make that acceleration work better.
Dr. Stone, you're blowing my mind. I did not know that it is now possible to regrow old cartilage. I thought once your cartilage was worn out, it was done. Is this something which is new? Is it proven? Is it becoming more valid as a confirmed type of treatment? And it is more than just experimental.
Hello, friends. Just a quick break. This is not an ad. If you have been enjoying these conversations, I would love for you to subscribe to my newsletter. It is where I go deeper, sharing stories, reflections, and behind the scenes insights that don't always make it into the podcast. I write about what I'm learning from elite athletes and how to stay ageless in body and mind. If you have ever wanted a thoughtful, inspiring read that ties it all together training, aging, mindset, and awe. You will love this. You can find the link in the show notes or just head to agelessathlete.co. Again, www.agelessathlete.co, that is, to sign up. And yeah, just a couple of emails a month, and you can unsubscribe anytime. Absolutely no spam ever. Okay, back to the show.
Yeah, so we've published both 2 to 7 year follow-up studies in peer-reviewed journals. We also published 2 to 25-year follow-up study on the biologic reconstruction of knee joints. I lecture around the world at various meetings. I just gave a talk at the International Cartilage Repair Society meeting in Boston. I think cartilage regeneration is an accepted technology now. There are lots of different approaches towards cartilage repair. We feel confident in the way that we do it using a pacecraft technique as we think is the best one for almost all the situations that we see. And it's probably the only one indicated in arthritis. There are a number of other techniques indicated in what's called an isolated chondral defect, when you have a small hole in the cartilage, and there are different ways to plug those holes. But in the setting of arthritis, the pacecraft technique seems to be the best and the only one really indicated there.
And just to be clear, Dr. Stone, are we just talking about cartilage in the knee here, or are you also saying that the cartilage in other joints that were mentioned, like the ankle, shoulder, etc., those can also be grown the same way?
So our experience with cartilage regeneration is primarily in the knee and in the ankle. There's an excellent foot surgeon at my surgical center. I've taught him how to do the cartilage procedure for the various toe joints that he operates on. So I know that it is done in other joints as well. The shoulder and hip have been extremely difficult because of their shape and their anatomy. So I can't offer, and I don't operate on hips, I can't offer that same optimism in the shoulder. But knee and ankle are definitely treatable with cartilage regeneration techniques, and we're optimistic that we'll get better and better at these.
Wow, it's so incredible. Let me ask you this rather general question, so folks have a sense of how innovative and how just life-changing these treatments can be. So can I ask you to hazard just a guess, just back of the envelope guess, with if there are 100 knee replacement surgeries that happen, let's say, each day, how many of them would be preventable, still allowing the candidate to regain full function with the type of intervention you are talking about?
Yeah, so there are different ways of looking at that. There are about 450,000 artificial total knee replacements done in the US each year. It's said by one study in England that 80% of those could have an alternative treatment, meaning a partial knee replacement or a biologic intervention. So there's a substantial number of people who, when told to have a knee replacement or told to wait for their knee replacement, should look at what their other options are. It's just, you need to know the bias of your surgeon. So I'm biased. We've spent years developing these biologic techniques and these robotic partial knee replacement and total knee replacement techniques. So we've spent years working with athletes. We're all athletes here as well. So we're very biased towards the side of helping people play sport and helping people just treat the part that's injured and not take more risk of replacing uninjured parts of the knee. And we're also humbled by the fact that we know that if we do a full artificial knee replacement, it's not really a normal knee, and they have a failure rate. And we like to do things where we can bail out if there's something that goes wrong or they doesn't last them as long as they want. And once you do a full artificial knee replacement, it's very difficult to revise it properly. So we're biased towards biologic interventions, towards partial knee replacements, in the ankle towards cartilage grafting, and avoiding fusion in ankle replacement. Let's just speak to that ankle for a minute. So many of the people we see from around the world have been told after their trauma to their ankle that they had only two options, an ankle fusion or an ankle joint replacement. And we've learned over the years that if we just go in and recreate that ankle joint, even in very difficult arthritic ankles, we can get a biologic healing response that works quite well for patients. So it's a great example where we all thought there was nothing that we could do, but we now know that we can biologically treat these ankles that otherwise look destroyed. It's very different than the knee joint, by the way. Once the knee joint is truly destroyed and bone on bone, we have to use artificial materials. But there's something quite unique about the ankle. Let me explain that a little bit more. You're walking around with your entire body loading on that tiny little ankle joint, only on one side with each step. And yet the ankle never becomes arthritic unless it was injured, unless you had trauma, fracture, or dislocations, instability. The ankle just never becomes arthritic on its own. There's something unique about ankle cartilage. And so we can take very damaged arthritic ankles and regrow cartilage in them when we otherwise didn't think we could. And we can't in a knee joint when it's so severely damaged. So we're learning about the unique aspects. All cartilage is not cartilage. They're all a little bit unique. And every individual is unique as well, what their goals are and their desires, their healing ability, their likelihood to form scar tissue. People are remarkably unique. So we don't see that there's any standard procedure. We don't think there's any standard patient. We think everybody really needs a thoughtful, individualized approach, and people respond very differently. So if you're the patient, I would tell you explore your physician's biases. Just ask straight out. People ask me all the time, and I tell them all the time. And if the physician's biases match your own biases and your own desires, then you're probably heading down the right path. But if you're heading down a path or your goals are to play one sport or be able to run or be able to climb, and your physician's attitude is no, don't ever do that, you're probably in the wrong hands. So I think exploring that, understanding that really helps you get the kind of care that you want to get.
Appreciate that. I mean, I think most people listening would say that their bias is for sure for being able to regain full function of their injured joint. And they would want to work with a specialist who will help them get there. But to what you said, there are different paths to getting there, and different paths have different levels of surgical trauma and different levels of long-term effectiveness. However, what I can see from the approach that you have, perhaps your approach is less invasive and may be more promising because of some of the data that you shared. For sure, the fact that the recovery times and just the time under surgery, those right away seem just more palatable than going in for a total joint replacement. And because this term is going to be repeated through this conversation, I think it would behoove us for me to ask you right away. So what is a biologic replacement or scaffold, I think is the term used, and how is that really different from the simple trim it and go approach with arthroscopy that has traditionally been, I think, the mechanism?
So arthroscopy is the tool for looking inside the joint. And then what you do when you're there is either you can take tissue out, you can smooth tissue down, or you can put tissue back or repair tissue. And so what we like to do whenever possible, a biologic joint replacement means that if you're missing your meniscus, or you're missing your articular cartilage, or you're missing your ligaments, or they're torn, we want to either repair, regrow, or replace those tissues. And so, I'll see somebody that needs everything. So tomorrow I'll do a biologic knee reconstruction where the patient needs a new meniscus cartilage put in, needs a new ACL and an extra articular graft to control their rotation, needs their damaged articular cartilage grafted. So we'll use a paste graft technique in order to do that. And we'll do that all in an outpatient surgical environment, and then they'll come into the clinic the next day and start their rehabilitation program. So that's what a biologic knee replacement is. On the other hand, if we see somebody that has worn their knee joint down to bone on bone, has no joint space on one side, then in that case, we'll often do a partial knee replacement. That's when we use a robot, put a metal cap over the end of the femur and a little tray on the tibia, just only on the side that they've damaged it. And that can either be on the medial side, the lateral side, or just at the patellofemoral joint. See a lot of people with anterior knee pain where they've developed severe arthritis of the kneecap, and we can just resurface that area and not touch the rest of the knee. So in the knee joint, those are the common things. In the ankle, in the Achilles tendon is a nice one to talk about that we haven't mentioned yet. So many Achilles ruptures get open surgery. And we've learned over the last couple of decades, that they really don't need open surgery. We can repair those ruptured Achilles tendons with what's called a percutaneous technique, where we weave a suture underneath the skin and never make an open incision there. And so we don't lose that natural normal blood clot that forms around the ruptured ends of the Achilles tendon. So these are techniques and biases where we're able to bring repair methodology to damaged and missing tissue.
Amazing. Again, just for people who are listening who might immediately be interested in exploring this type of intervention, can you provide to us what the current landscape is of being able to find a clinic? Let's say somebody's interested and they are not able to find time with you, either because of calendars or maybe they just happen to live in a different place far away. Are these procedures becoming more and more common? So if somebody lives in, let's say, Australia or Canada or a different part of the US, can they find somebody who can help them evaluate if a biologic replacement is indeed viable for them?
Sure. So for information, they can look on our website at stoneclinic.com and go under videos, or if they want a consultation, they can go under consults. And we do lots of these remote consults for people from all over the world. And they can also look, if they're interested in the research part of it, they can look at stoneresearch.org and get information about the research aspects. And I think, most of our patients are looking at ChatGPT and other AI methodologies of looking up biologic knee replacement or avoiding total knee replacement. And that usually will lead them to surgeons who have that kind of bias. So I think the tools are out there. I spend my time running around the world lecturing and creating surgical videos and trying to teach the methodologies that we develop. And so there are a lot of us who are passionate about trying to move this field forward. And it's exciting. It's fun. We get to take care of people who are just like us who want to keep playing.
Beautiful. Yes, it is correct that a lot of information is at our fingertips now, but sometimes that also adds to the confusion, adds to the noise of where to go for a trusted source. So yes, we'll put links and people are encouraged to visit your website. I know you publish regularly and they can assess based on the information you have provided. So what I'm understanding is that each person is different. The treatment that you will advise will be different. Yes, there likely are situations when a total joint replacement is indeed warranted, but those will be more rare than was advised even just a few years ago. One other area I would love for you to help unpack for us is, so when it comes to, again, these joints, the ankles and the knees, but also the shoulders and the hips, there are a lot of buzzwords that have come up in the last several years. One hears of stem cells, one hears of PRP. I'm sure you also hear of others in the medical community and also your patients talking about these terms. So can you help us separate what is real and what is the hype? And are these other therapies generally helping people today?
So the answer is yes, they are helpful. And let me explain, though, again, my bias for your listeners so that they can sort through the various therapies that they're being asked to have in their own joints or their own body. So in general, you need to know that you as the patient sitting there, no matter what your age, have billions of stem cells within your body. They're called pericytes. These are cells that live on the walls of vessels. And when you have an injury, even a simple injury, falling down on a sidewalk and banging your knee or your muscle or football injury, there's a siren call out to your body's own stem cells to rush to that site of injury and direct the healing response. And that's how normal healing works. So as a physician, especially one interested in these biologic therapies, my job is to figure out what to do to accelerate your healing response. Now, traditionally, what we use is physical therapy, soft tissue massage, ice, heat, elevation, and then surgical repair to try to get these tissues to heal. And what we have now is an ability to inject factors that accelerate your body's response to make that healing occur. So What are the factors? Number one, there are lots of these factors in your own blood. And so we use your blood to take your platelets and get them to release these granules that have lots of growth factors in them. And those growth factors work both locally to help the healing, reduce inflammation, stimulate new collagen production, reduce inflammation. And they also work to recruit your body's own stem cells to that site of injury. You can choose to add additional cells from your bone marrow, from fat, from someone else's bone marrow or fat, from birth tissues. All of those things are potentially helpful at increasing the healing response. But the reality is, what we want to focus on is the most potent recruitment factor for your body's own cells. So when you go somewhere and they say, hey, we're going to inject 1 million cells or 10 million cells of whatever, you should be sitting there thinking, hey, it's not really the number of cells you're going to inject, because those cells probably die or probably don't stay at the site of injury very long. What I really want you to inject is the most potent recruitment factor for my body's own cells, because I'm sitting here with billions of stem cells ready to respond to this injury. So many of our patients and people we see from around the world have gone to Mexico, have gone to wherever to get cells grown in tissue culture and then injected into them. I think they've wasted their money, because it's not the number of cells, it's really the recruitment factors. So that's where I think the field is today. Our research is on how we do that more potently. And I think you want to use the most cost-effective therapies and injections that work best for your individual problem. And then you want to potentiate that injection, meaning how do you make that thing work better? And you do that with exercise, with soft tissue massage, with energy. So the shockwave therapies that add energy to these injections augment how they heal and make them heal better. So in general, every time we're doing a injection of these factors into someone's injured tissue or arthritic knee, we're almost always encouraging them to stay around long enough to do a shockwave therapy type approach or other approach, soft tissue massage therapy, whatever they can do in order to augment that healing response. So stay tuned is what I would tell your listeners. Be very cost effective. However, these injections, if done safely, can be quite helpful in a lot of circumstances.
Dr. Stone, I mean, you've just dispelled this huge myth about it's not the quantity of the stem cells that's going to make that difference. Your body already has all these other stem cells waiting as receptacles. So yes, I think that's really pointedly helpful right there. I'm trying to understand or make sense of all these different possibilities, maybe almost this buffet of treatment options. And maybe it's not a buffet. So I think maybe I should ask a very simple question first. So in your clinic, do you also provide PRPs and stem cell therapies to patients, or do you point them?
Every day. It's a big part of both helping people avoid surgery, help people accelerate their healing from an injury or from surgery, or help people have a surgery work better.
Perfect. So let's use a real world example. Let's say you have a 50-year-old skier or runner who walks into your clinic with pain, with knee pain. How would you go about helping this person and helping them sort through, either examine different options or combining these different options to allow them to move past pain and get back to full long-term health of their knee?
Well, the first thing is a good history, understanding how they got injured and what the symptoms are. A very careful physical exam to understand their gait, their mechanics, their walking and running gait, their range of motion, where they hurt, how the tissues feel, how loose they are, whether they're unstable, a host of those factors, just by careful physical exam and history. X-rays and MRI are almost universal in part of making the diagnosis. We do that right here in the clinic, so we can have clear pictures of exactly what the injury is. And a physical therapy assessment of the patient as well, because we learn so much from our physical therapists and athletic trainers, things that we sometimes don't pick up ourselves, or the patients tell them, or that they see from their perspective. So the entire team looking at somebody, a 50-year-old walking in with a particular problem, has got to come together to understand what's the injury, What's the right path to get that person back? What are their goals? How are we going to get them there? The other thing is that trying to help people see their injury as an opportunity. So bad luck, you injured your knee, but we have all these resources to help you, treat yourself like a pro athlete would treat themselves. Use this injury, become fitter, faster, and stronger, as we like to say, than you've been in years. So if we're going to spend a few months helping you recover from something, why not train your entire body, your core, your cardiovascular program, all the rest of your physique, so you come back to whatever sport better than you've been in a long time. So I think if the patient can adopt that mentality, then all of the things that we can bring to the table to help them get better just work better, and it's more fun and it's more satisfying for them and for us. So it's a partnership between us and the patients, and the better we do with that, the better they do.
That sounds so comprehensive. Yeah, I mean, if you're starting right with understanding their movement history, their injury history, their gait analysis, and their future goals, I guess all of those will likely yield to a more long-term outcome. Tangentially, talking of gait analysis and talking of just body alignment, many people are often born with, let's say, undiagnosed alignment issues. It could be things like flat feet to knock knees or bow-leggedness to maybe even hip dysplasia. So the interventions that you are executing, can they also help correct for some of these issues? And the reason I ask is one can go in and make that one-time partial joint, like one-time intervention to the injured joint. But if one is not able to, let's say, correct some of the root cause with misalignment, perhaps there's a higher possibility that those injuries will come back. So do you help correct some of those foundational issues that people might have with their alignment?
Sure. So the way we say it is that bad biomechanics will destroy good biology any day of the week. You can put new tires on your car, but if the car's out of line, the tires are going to wear out too fast, right? So a big part of what we do and our rehab team focuses on is trying to help people optimize their mechanics. So if you've been walking with a painful knee for a few years, most likely you're walking badly, your hips are affected, your back's affected, your ankles affected. We do see the person as an entire person and an entire athlete, so we want to focus on all of it.
Yeah, poor biomechanics will linger. Whatever intervention you put forth, if those are not improved upon. So what we are saying is that these treatments will be done together, will be done as a combination based again on the individual in practice. Now, I'm not sure how long have some of these interventions been executed by you, your team, and others, but can you also give us a sense of what has been the experience longer term? So again, this is somewhat new, but you have been practicing this for some time now. So could you maybe either use some real world examples or just overall data on where are those patients who have had these interventions over the last several years, and how is their health and their lifestyle today?
Sure. So we published a 2 to 25 year outcome study on biologic knee replacement and looked at patients who had severe, cartilage damage and loss of meniscus, and what happens to those patients after you replace the cartilage and replace the meniscus, or regrow the cartilage and replace the meniscus. And we know that about 80% of them at the 17-year follow-up on average were happy with their outcome playing sports and were improved. And so we know it's not perfect, that the knees aren't perfect, but that we can get good enough cartilage repair to keep people being active. And that's our goal. And that was before we were adding all these additives to stimulate healing. So we think today the data will be better.
Sure. And maybe we should also just provide listeners a sense of what might be some of the financial outlay of seeking this kind of treatment. So in the US at least, are insurance plans covering these, let's say your general insurance plan, are they covering this type of treatment?
I can't really speak to it specifically because every plan is totally different. And it really depends. They'll cover parts of one thing and not parts of another. There's just so much variation that I stay out of it.
Okay, fair enough. And maybe just one last question on this, just the research and what's going on. So we spoke about what is happening today with what's available. What is, in your mind, the next wave or the most exciting research or breakthrough that gets you excited and up at night with what is yet to come?
There are two major spaces. One is that I think we'll have better injections. We'll figure out how to use birth tissues better than we're using them today. There's nothing growing faster than the fetus, and the fetus is only half the mom, and yet it's not rejected by the mom. So there are potent growth factors, immunomodulatory, antifibrotic, anabolic, stimulating factors that are in birth tissues that we will use more effectively than we're using today. If there is a fountain of youth, it's the birth tissues that we should be able to apply. The second major area that we are involved in research on and that I think will affect people is we need to be better at bioidentical hormone replacement for both men and women. There's no such thing as the field of male hormone replacement therapy right now, although there has been the field of female hormone replacement therapy, mostly with estrogen and progesterone. But the reality is that there are a wide range of hormones and peptides that will affect you as you age. And so, as you know, all men and women are losing muscle mass and bone mass with aging. And we should be better at being able to restore a number of the hormonal factors that affect their aging tissues. And we're very poor at it right now. You've heard about testosterone, but you think it's involved only in weightlifters, data from 20, 30 years ago. The reality is that probably most men and women should have some type of testosterone replacement as they age because they need the testosterone, their muscles and bones need it, but we just haven't had the right kind of guidance and protocols to figure out how to use it properly. Women, fortunately, have figured out how to use estrogen and progesterone to diminish the effects of aging and menopause, but men have not figured it out at all. So I think that there will be tremendous progress in this space. I think it's a very exciting space. It includes the whole space of peptides, as we've seen with peptides for weight loss. There's just so much more potential in that space, and it'll be very exciting.
Super exciting, Dr. Stone. Initially, when we were talking, you spoke about how upper body, maybe specifically the shoulders, we are not quite as far along yet with being able to implement or at least evaluate the same type of treatments that you have now described for us for the ankles and your knees. So what is your perspective on when can healing methods for the shoulders catch up? Because a lot of overhead athletes start getting bogged down by shoulder issues once they hit a certain point.
We're actually gotten pretty good at shoulder soft tissue repair. We're just not very good at shoulder cartilage repair yet. So, shoulders that are getting arthritis have limited options. We're pretty good with injections. We're pretty good with tendon tissue repair, which is not very good at cartilage restoration procedures. I think they're quite far behind. Same in the hip. So we do things to help buy time. We help patients restore their musculature and their tendons and their rehab and their injections, but we don't really have good techniques to delay their arthritis yet or treat their arthritis properly. It'll come. It's just, it's behind.
If you're craving more presence, clarity, and emotional truth in your life, Courageous Alignment is your new weekly ritual. Hi, I'm Cher, and each episode blends psychology, astrology, and grounded healing tools, including meditation, to help you reconnect with yourself and move through life with intention. If you're ready to live with more courage and more alignment, join me on Courageous Alignment wherever you listen to podcasts. I'll see you there.
What about these other options to help either restore some function or maybe just degrade the growth of the arthritis by using, again, PRP and stem cell? Are these procedures as effective for the shoulders?
They are still effective. They're really the only tools we have once we repair the soft tissue. So we're using them extensively in the shoulder and hip, even though we don't have the surgical techniques that we wish we had to regrow those tissues. So it is the technique we have. So when we see arthritic shoulders, we're injecting them and rehabbing them quite a bit. We repair the rotator cuffs and torn labrums, of course, but for the cartilage side of it, we're mostly doing injections.
And how many years away do you think are we before we can walk into your clinic and ask for the same kind of cartilage regrowth that we have?
I don't know the answer to
that. Fair enough. Fair enough. Okay, great. So moving beyond surgery, I love the fact that you speak about rehab and return to the sport extensively. So once the surgery is done, then the real work begins. And so from everything you've seen, what separates the people who come back stronger than from people who plateau and don't have the same successful outcome?
Good biology, good head, good motivation, great physical therapy, great attention to detail, giving themselves the time to spend in rehab and fitness training, setting real goals and achieving them, just being determined to not let anything get in their way. If they have a problem from the surgery, meaning they form scar tissue or a painful spot, undergoing a second procedure if they needed to tune it up, getting access to good injections in the post-op period to augment the healing. All of these things play a huge role in how fast and how well people heal.
So much of your philosophy, Dr. Stone, with medicine seems to be about just holistic care and about being able to maintain one's faculties as athletes or lifelong athletes. So do you find that when people come to you for treatment, do you think many of them walk away with that mindset of being able to use their body and being able to continue that rehab for as long as it is needed?
It's the criteria by which we use to treat them. So it's a partnership between me and the patient. I give you my best surgery and best care and best injections and best research information. You have to give me your best effort at all the rehab and your side of the deal. And if we have that contract together, we're likely to succeed. And if we don't, then it's probably better that, we may not be the right fit together.
Okay. Yeah. That makes a lot of sense. And I certainly appreciate that you put forward that expectation clear and center that it doesn't end when somebody walks home post-surgery. They have to shoulder that work ahead of them in order to get
it's more than that. We see our patients as friends for life, or we want to see them back at the clinic for regular fitness checkups, and how can we help them at every stage as they get older and as the years go by. And so we do fitness tests and sport tests and research outcomes, and so we try to never lose track of the patient.
Excellent. Yes. On that note, I thought I would also ask you, we talked about these interventions which come with surgery. What are some things that people listening can start doing once they start experiencing the, let's just say, early onset of pain in their joints? Maybe just, it could be pain, it could be just lack of mobility, it could be something else which is not quite serious enough to warrant something like surgery, but something they can start doing today to restore vitality, restore movement, maybe delay coming to you for getting things fixed.
I think the earlier you make an accurate diagnosis and the earlier you get started on your rehab and treatment plan, the more likely you are to do well.
Fair enough. So you have treated elite athletes and everyday people who are trying to continue their sport. Could you maybe share a quick story, Dr. Stone, on that captures what's possible? Maybe someone who came in who was broken and ended up surprising with their outcome.
Sure. I mean, the most dramatic patient was somebody who came in and said, "Listen, I want to run, across the United States, and I've got bone-on-bone changes in both of my knees." And so we did partial replacements for him, and I think about 7 months later, he did his run across the United States. So
wow.
That's after both knees being surgically repaired. So I think that partial knee replacements were a superb option for that patient, and getting rid of the mindset that you're limited is an important aspect of it.
Wonderful. I'll ask you one last question. Dr. Stone, you're not just helping other athletes. You are one athlete yourself. So what is your own formula these days for staying active and injury-free?
It's the same thing I tell all my patients. It's really important to exercise every day. That every day, because then you become addicted to it. And once you're addicted, then you feel badly when you've missed a day. And so that addiction to the endorphins and the hormones and the adrenaline and the pheromones and all the good things that happen from exercise. And by the way, all of the research on longevity, every single possible longevity treatment that you might seek out, none of the data is as effective as daily exercise. Daily exercise lengthens the telomeres, improves the tissues, improves your mental outlook, optimizes your body weight, improves your appetite, does everything that any longevity therapy does. And so if you want to live longer, exercise every day, and then treat your tissues in a good way. Don't let yourself degrade. If you have an injury, treat it and try to get the best care you possibly can.
Wonderful, Dr. Stone. Brilliant parting words. Thank you so much for giving us your time today.
My pleasure. One last comment. For those of you who like to read books, so I wrote a book called Play Forever, and it's on Amazon, and it summarizes a lot of the things we talked about today and goes into a lot of other subjects as well around staying healthy, living longer, and playing forever, which is my goal to help every patient do.
That's it, folks. Thanks for tuning in to this episode of the Ageless Athlete podcast. I hope you enjoyed this show just as much as I enjoyed creating and producing it. Whether you are an athlete looking to push your limits or someone striving to maintain a healthy, active lifestyle as you age, there is always something new to learn. From Ageless Athlete, we bring you a fresh episode each and every week. If you liked what you heard, we would love it if you would take a moment to subscribe to the podcast so you never miss an update. And if you really liked what you heard, please leave us a review, crush those 5 stars on Spotify or Apple Podcasts or wherever else you listen to your podcasts. It helps us reach more people who are passionate about staying strong and resilient, no matter their age. Don't forget to visit our website and leave your email so I can send you occasional insights, stories, and tips to keep you inspired and motivated on your journey. You can also follow us on Instagram at Ageless Athlete Podcast and on YouTube at Ageless Athlete Podcast as well for even more great content. All of these links are available on the show notes for this episode. This show is entirely produced by me, Kush Khandelwal, based out of California with the help of my trusted adventure pup Roger. Until next time, keep challenging yourself. Keep pushing those limits. Stay mentally and physically fit. Continue doing what you love to do. And my friends, stay ageless. Friends, this is not an ad. This is just a quick message to those amongst us who are listening to Ageless Athlete podcast for the first time. I would love it if you would hit subscribe and follow on your favorite podcast app, whether it's Apple Podcast or Spotify or Stitcher or Overcast or what have you. We bring you stories and routines and other inspiration from elites in the world of the best outdoor sports. In each episode, you will find how these athletes stay connected to the outdoors, maintain peak performance, and continue to thrive as they age. I encourage you to look through prior episodes and listen to a couple and see if they resonate. And then, come back next week. We release an episode each week. And I am really inspired to bring you some of the best stories from the world of the outdoors. Okay, back to the show.